a very simple picture of how the lung is formed. Okay, so from a primitive lung bud, it is getting branched out to two main bronchi, and then from those two main bronchi there are lots of canaliculi are forming, and those canaliculi you have again sacs. So saccular terminal saccules are forming, and those bud into and form the alveoli. So this happens from 3 weeks till the infant is born, and then the alveoli will continue. The alveoli, more and more alveoli are forming even towards the adolescence. So when the baby is born at say 26 weeker, so how will the lung be? It is only at the canalicular stage. The terminal saccules are not formed. So if there is an inflammation here, what happens? It impedes the development of terminal saccules and more of alveolar formation. So the cells will be very, very primitive. Those type 1, type 2 alveolar cells are also only forming hereafter. So if in case there is an inflammation here, a 26 weeker born and we are giving hyperoxia, the baby is under sepsis, so many antibiotics are given, the mother's own milk is not given, enteral feeding is not established, what will happen? So much of lung inflammation, these so sophisticated or the differentiated alveolar type 1, type 2 cells, the lamellar bodies are not formed. So what happens? The lung will not repair. So these babies, the severe BPD babies, will have implications throughout their life. They have, I will tell you what all they will suffer from, but they will have implications throughout their life only because of this. So understand, this is a very simple but a very, very beautiful and a thoughtful diagram. Again, whatever we have discussed so far, I am just not going to repeat this. So this is an alveoli which is subjected to all triggers from outside. Okay. So how does BPD present? So this is the definition that I am going to come again. So definition, we know less than 32 weeks babies, at 36 weeks you are evaluating, and if the baby is dependent on oxygen for 3 days or more, then we call it as BPD. So that is oxygen dependency. It is not just oxygen dependency, any need for respiratory support or supplemental oxygen we will tell as BPD. BPD spells. So once at 36 weeks post gestational age, you have identified that this baby has BPD. There can be BPD spells in these children, which is a very, very important clinical feature. BPD spells, like we have heard of the term spells when we are talking about breath holding spells, apneic spells. Similarly, this is a BPD spell. So what will happen in a BPD spell is there is an acute event which will happen where there is a transient elevation in pulmonary artery pressure. Okay, so what will happen? Because of the elevation of the pulmonary artery pressure, there will be right to left shunting intracardiac. Okay, so there will be a right to left intracardiac shunting. That is because of abrupt elevation in the pulmonary artery pressure. These BPD spells are very, very difficult to control, and we need to give supportive care. We need to increase their support, oxygen, and we can treat them with bronchodilators. So this is about the BPD spell. So when there is a BPD spell, what will happen? There will be hypoxia, hypercapnia, and the existing respiratory status will worsen. Complication of BPD is of course pulmonary hypertension, because BPD further increases the pulmonary arterial pressures, ultimately leading to pulmonary hypertension, and this should be confirmed by our echo. And this pulmonary hypertension is more and more common with lesser gestational age, that is less than 28 weeker, and infants who are born at less than 1000 grams. And those babies with pulmonary hypertension can progress to right heart failure, that is cor pulmonale, ultimately leading to death in these babies. These are the different chest x-rays. I mean, it is not of a single neonate. This is from the Nelson textbook. What has been mentioned in the textbook is that is BPD, there is no pathognomonic chest x-ray finding. Okay, so it can start like a respiratory distress, where you can see that this is a ground glass appearance. Okay, so completely opaque, opacities are present bilaterally, it's a ground glass appearance. So next it moves on to the small infiltrates are present bilaterally, and finally it has become, it has evolved into pulmonary hypertension, right side heart failure, finally causing cardiomegaly, hyper expanded lungs. This is a post-mortem picture. So this is a dilated heart with, these are the lungs. So lungs look very, very heterogeneous, not aerated completely. Okay, and this is an irregular aerated lung. So, the pulmonary changes can be very different, and there is no particular pathognomonic finding for BPD.